for the fourth annual ALMER and ACCER Symposium for the opportunity to open this talk and discuss adjunctive therapies in the management of severe male infertility. For disclosures, I will be discussing some off-label treatments, meaning some medications that are not indicated for the specific use under FDA or other approval. I'm also declaring my financial support from different organizations which do not have any conflict with the contents of this presentation. I will be talking about controversies in the management of non-obstructive azoospermia, routine management for men with non-obstructive azoospermia is sperm retrieval and IVF. I'm going to talk about the treatment of low testosterone in the infertile male. I'm also going to talk about adjunctive therapy of men prior to sperm retrieval in an attempt to enhance the ability of sperm to be found. That's going to include non-specific medical treatment, including the use of selective estrogen receptor modulators or SERMs like clomiphene, as well as aromatase inhibitors, as well as gonadotropin treatment. I'm also going to talk about varicocele repair and its potential role in the management of men with non-obstructive azoospermia prior to attempted sperm retrieval. So non-obstructive azoospermia is the most severe condition in male infertility. It reflects sperm production that is so impaired that no sperm appear in the ejaculate. Even men with azoospermia can have occasional sperm detected in the ejaculate with an extended sperm preparation. And that's because the standard laboratory evaluation for azoospermia doesn't analyze all of the contents of a centrifuge semen pellet. So again, even the definition of azoospermia needs to be confirmed prior to proceeding with surgical sperm retrieval. However, men with confirmed azoospermia are very difficult to treat. Typically, sperm retrieval rates are reported to be low. Impaired fertilization rates occur even with the application of our most effective assisted reproductive technologies like ICSI, and embryo development can be affected by low sperm production. Taken together, this results in lower pregnancy rates for men with NOA than those achieved with sperm from other sources. So this is a photomicrograph taken through an operating microscope of a man with typical non-obstructive azoospermia. Total testicular length is approximately 1.5 centimeters, far shorter, far smaller testis than the usual 4.5 centimeter normal testis. Non-obstructive azoospermia is associated with a series of conditions that can cause or be associated with low production, including cryptorchidism, Klinefelter syndrome, Y chromosome microdeletions, and men who have received prior chemotherapy or radiation. However, a wide variety of men have idiopathic or undefined causes of non-obstructive azoospermia that are only able to be described by their pathologic appearance as being Sertoli cell only or maturation arrest. Certainly for men with non-obstructive azoospermias, we talked about controversies in the definition. No sperm in the ejaculate is expected in azoospermia. No sperm in a centrifuged or concentrated semen specimen is also expected. However, for true azoospermia to be present, no sperm should be present in an extended preparation of that centrifuge or concentrated semen specimen. Again, it's clearly a difficult condition to treat, which has led a number of investigators around the world to go to somewhat desperate measures to try to enhance treatment success. I consider these desperate measures because we don't have good data to support them. there are limited controlled trials that actually allow us to improve treatment success in the micro-TESE and IVF management of non-obstructive azoospermia. We know from observations that within the testis, the areas of sperm production depicted in black in the seminiferous tubules of the testicle tend to be very limited. For men with non-obstructive azoospermia, those sites are not geographically predictable, as being in the upper pole, lower pole, central, or peripheral regions of the testis. Sperm production, though, is typically present throughout the few tubules that are making sperm. One exception, of course, are men with Klinefelter syndrome, where the areas of sperm production are often focal along a tubule with intervening areas of sclerotic seminiferous tubules. The approach for sperm retrieval is extraction of sperm from the testis. By definition, men with non-obstructive azoospermia can only have sperm found from testicular tissue. So testicular fine needle aspiration, testicular sperm extraction, typically with multiple random biopsies, or microdissection testicular sperm extraction, or micro-TESE, a directed approach for sperm retrieval, have all been applied. There is certainly variable experience at different centers because of the heterogeneous populations of men that we see with non-obstructive azoospermia. Improper systematic reviews of these men with mixed evaluation of different populations, surgical procedures, and experience have resulted in confusion in published literature. Only comparative trials that look at different approaches should be considered when trying to analyze what's the best approach to sperm retrieval. One of those meta-analyses was done with almost 1,900 patients treated. Only studies that involve direct comparison within patients of TESA, fine needle aspiration mapping, versus conventional TESE, or conventional TESE versus micro-TESE were included. The conclusions of that meta-analysis are that conventional TESE is twofold better than TESA, or fine needle aspiration and mapping, at sperm retrieval. And micro-TESE is 1.5-fold better than conventional random biopsy TESE. The micro-TESE procedure itself involves widely opening the testicle in an anatomic, relatively avascular plane in the equatorial region of the testis, and then allowing dissection parallel to the seminiferous tubules and parallel to the blood supply within the testis. This allows the surgeon to examine and look at wide areas of the testis without disrupting the testicular parenchyma. The safety of micro-TESE has also been well demonstrated. The amount of scar tissue that develops within the testis is less after micro-TESE than after conventional multi-biopsy procedures. Similarly, testosterone levels are better maintained after micro-TESE than conventional multi-biopsy TESE. So clearly the surgical approach of micro-TESE is more effective and safer than conventional sperm retrieval approaches. Preoperative treatment in non-obstructive azoospermia has recognized that many men with impaired sperm production also have low testosterone, and low circulating total testosterone could reflect low intratesticular testosterone. Since intratesticular testosterone is important for spermatogenesis, attempting to increase endogenous production of testosterone with SERMs, aromatase inhibitors, or HCG has been attempted. It's important to distinguish the treatment of men with low testosterone from nonspecific or adjunctive therapy without a specific abnormality being treated. So the recent joint guidelines of the American Urological Association and ASRM said that treatment in the setting of documented low testosterone is a standard for male infertility. that clinicians may use any of these agents, aromatase inhibitors, HCG, or SERMs, and evidence to support this exists at a high level. On the other hand, guideline panel assessment of published literature was that there is only very limited evidence for preoperative treatment in men with non-obstructive azoospermia. Really only one randomized control trial of 52 men, two prospective comparative trials, one retrospective comparative study, and the one RCT for letrozole included more cryptozoospermic patients, men who already had sperm in the ejaculate, than azoospermic men. They were men with low testosterone and an abnormal, meaning low testosterone to estradiol ratio. Men were treated with 2.5 milligrams of letrozole for 6 months. Outcome of sperm detectable in the ejaculate occurred for all men treated with letrozole and none with controls, surprising because most of the controls were cryptozoospermic at the beginning of treatment. There were no natural pregnancies with letrozole alone. HCG treatment before non-obstructive azoospermia treatment with sperm retrieval has been done with HCG. 34 men with normal LH-FSH and testicular volume were treated for 10 to 14 weeks prior to TESI. Sperm retrieval rates were 50% in the HCG group, 57% in the control group, and similarly, pregnancy rates were not affected by using HCG or no treatment prior to an attempt at sperm retrieval. A beneficial effect of clomiphene citrate has been reported in one study, but this was a complex, non-randomized comparative study with stepped therapy, meaning increasing therapy based on initial response. They compared 496 treated men with clomiphene to 116 comparators who did not receive clomiphene. There were problems with the study in terms of non-consecutive enrollment. There was also baseline characteristics of the patients between the groups were not compared. 11% of the treated men had sperm return to the ejaculate, with a 57% sperm retrieval rate with TESI after clomiphene and 34% retrieval rate with controls. But again, even though this was a positive study supporting clomiphene use, the quality of evidence in the study is very low, and it's a single study. FSH treatment has also been tried before TESI. One study of 108 men with NOA who had abnormal spermatogenesis on biopsy, a normal FSH, meaning less than 8, and no identified cause for NOA, were treated with FSH injections 3 times per week for 3 months. They're compared to 45 controls. FSH treatment was reported as having a 64% sperm retrieval rate versus a 33% rate in controls. But again, this was not an effective randomized controlled trial with problems with allocation. In terms of combined hormonal treatments, a retrospective study of 736 men treated with a combination of either clomiphene, aromatase inhibitors, HCG, or a combination thereof, showed that men with low testosterone had a 53% retrieval rate if they're treated with medication, a 52% retrieval rate if their testosterone was already normal. Just looking at men with a baseline low testosterone, those who were treated had a 51% retrieval rate, but those who had no treatment actually had a 56% retrieval rate. So again, in a retrospective analysis, no clear benefit of treatment. In terms of pre-treatment hormonal therapy for men with normal testosterone, the joint male infertility guidelines were that patients with NOA should be informed of the limited data supporting pharmacologic manipulation with SERMs, aromatase inhibitors, or gonadotropins prior to surgical intervention. We just don't have enough data to say that this is a worthwhile treatment. In terms of adjunctive therapy, there's multiple uncontrolled trials that have tried to use SERMs or gonadotropins after a failed TESI procedure in a salvage attempt at sperm retrieval. few or no studies have a control arm where sperm retrieval alone has been attempted without medical therapy. This is critical because repeat microtessy after a failed biopsy without any medical therapy has very similar sperm retrieval rates in the 39 to 46% range, again, despite an initial failed TESI attempt. How about varicocele repair prior to testicular sperm retrieval? Well, clinical varicoceles have known adverse effects on sperm production and fertility in men, and isolated studies have suggested return of sperm to the ejaculate in men with NOA and clinical varicoceles who had varicocele repair. Unfortunately, these studies have typically defined success after varicocele repair as having at least one sperm observed on a single semen analysis. Again, having only one sperm postoperatively may not be as important as having enough sperm to use for IVF. There's no documentation of return of adequate sperm to the ejaculate to avoid TESI except one study. So even though 36% of the treated patients in this combined series suggest that varicocele repair could have a role in non-obstructive azoospermia, it's not clear that it provides the sperm that are needed for IVF. One study that has looked at return of sperm to the ejaculate after varicocele repair in numbers adequate to avoid TESI suggested that less than 10% of men who have varicocele repair will actually benefit from that. And again, the finding of sperm in the ejaculate from men with non-obstructive azoospermia can be as high as 35% with no interventions. A meta-analysis of studies comparing return of sperm to the ejaculate in men with NOA who had varicocele repair versus those with no varicocele repair included 3 studies, but unfortunately, none of them were randomized controlled trials. That led to the guideline statement number 27 that for men with clinical varicocele and non-obstructive azoospermia, couples should be informed of the absence of definitive evidence supporting varicocele repair. And again, that's because of the lack of randomized controlled trials of varicocele repair in men with NOA and clinical varicoceles. Certainly, that is different from what is recommended for varicocele repair in oligospermia, where it is commented that surgical varicocelectomy should be considered in men attempting to conceive who have palpable varicoceles, infertility, and abnormal semen parameters. And again, that statement excludes men who are azoospermic because of the lack of randomized controlled trials to document benefit for those patients. As with many men and couples who are going through a process of treatment where they may have several steps along the way, it is critical that randomized controlled trials provide the data that we need so that you can actually analyze the benefits of an intervention if present. So in summary, talking about adjunctive therapy, which is clearly one of the controversies in non-obstructive azoospermia, we know that couples with non-obstructive azoospermia have sperm as the most limited resource, and doing everything possible to use sperm that's available is critical. Microtessy with IVF is the standard of care, and semen analysis just before a microtessy procedure is important because rare sperm could be detected. Treatment of low testosterone is considered to be a standard. Medical therapy prior to sperm retrieval for men with a normal or low normal testosterone is not currently supported by evidence-based data. Varicocele repair enhances testicular function, but for azoospermic men, varicocele repair prior to sperm retrieval may delay treatment and is not supported by evidence-based data. Again, thank you to the organizers for the opportunity to present at this Congress.